Hi, welcome back to your prescription for medication education. My name is Enmi, and I'm here to bring you quality information regarding medications and other health-related topics. And while doing so, try to make myself just a little bit better. And today I'll be starting on mucosal and other dosage forms. Today's objectives are pretty simple. I'm going to be briefly reviewing the oral and nasal mucosa, and I'm also going to be covering the dosage forms that we commonly see used in these areas. The types of mucosal routes of administration include buccal and sublingual, nasal, vaginal, and ocular. Rectal administration is also considered a mucosal route, but I already covered the rectal route of administration in my enteral dosage forms video. Mucosal tissue can be classified by type, function, and location. For example, simple columnar epithelium is found in the GI tract. Ciliated pseudostratified columnar epithelium is found in the upper respiratory tract, excluding the pharynx and the larynx, and stratified squamous epithelium is found in the vagina and certain parts of the oral cavity. The mouth surface area is small but highly vascularized. It consists of non-keratinized and keratinized areas. The sublingual and buccal mucosa are the most permeable areas because the epithelium covering these areas is non-keratinized. The sublingual mucosa has a thinner epithelium when compared to our cheeks, and for this reason, it's also more permeable. The buccal mucosa epithelial lining is a bit thicker, and this layer is replaced every 5 to 7 days. Our gingiva, hard palate, and the top of our tongue consists of keratinized epithelium, which makes these sites tougher to provide protection from the mechanical stress involved during mastication. Sublingual and buccal absorption reduces hepatic first-pass effect. Our saliva plays a role on medication absorption. It can reduce the contact time and absorption of medications that are intended for buccal and sublingual absorption by washing away the medication into the GI tract by unintentional swallowing. We can produce 1/2 to 2 liters of saliva daily. As noted in the previous slide, because the sublingual area is much more permeable, it's an excellent choice for when a rapid onset of action is desired. However, it lacks smooth muscle and is highly influenced by salivary washout. The buccal area contains smooth muscle and is relatively immobile. It is preferred for sustained release formulations due to longer contact time. The major mechanism for medication absorption is via passive diffusion, either through transcellular or paracellular pathways. Oral thin films are drug delivery systems that are quick releasing by dissolving in the saliva or adhering to the oral mucosa. Films are thin and flexible, non-brittle strips made of polymers that can be formulated with or without plasticizers. Some examples of polymers that are used are maltodextrin, hydroxypropyl methylcellulose, and cornstarch. Examples of plasticizers include glycerin, polyethylene glycol, and propylene glycol. Films can range in size from 2 to 8 centimeters squared and can be as thin as 20 millimeters to 500 millimeters thick. They are often formulated with saliva stimulants, sweeteners, surfactants, and coloring agents. They can be designed to dissolve within 1 minute of contact with our saliva. Some advantages of thin films include their overall ease of use, especially for those patients who have difficulty swallowing tablets. There's no need for water consumption to administer a dose, and they have a rapid onset of action. Some disadvantages include their hygroscopic nature. The active pharmaceutical ingredient must also be capable of absorption via passive diffusion, and they shouldn't be irritating to the oral mucosa. They're also limited to low dosages. Doses typically do not exceed 30 to 40 milligrams. Oral films can be categorized into 2 main types, which are oral mucosal films and oral dispersible films. Oral mucosal films are typically placed onto or under the tongue or the inside of our cheeks. These are designed to adhere to the inside of the oral cavity and release the drug at a slower rate for mucosal absorption. Now, oral dispersible films are designed to disintegrate on contact with the saliva. Oral dispersible films can either be orally disintegrating or orally dissolving, but the main distinction between the two is that oral dispersible films have absorption occurring in the GI tract. So essentially, just because a film disintegrates, it does not mean it dissolves. Disintegration allows for the film's contents to be swallowed. I actually found the term wafer to be quite annoying because it's unusual to classify, as the literature uses the term to also refer to wafers as a type of oral film, and I also seen it referred to as orally disintegrating tablets. Either way, generally wafers are a type of fast dissolving dosage form that is a thin and highly porous substance, and what makes it unique is how it's prepared. The method on how a wafer is made involves lyophilization, commonly referred to as freeze drying. A suspension or polymer gel of a drug along with its excipients is lyophilized to form a tablet shape. Their porous structure allows for rapid saliva penetration. Gelatin is the most common polymer used because it's biocompatible, biodegradable, and breaks down at body temperature. Medicated chewing gums are a semi-solid dosage form containing a gum base with an active pharmaceutical ingredient for both local and systemic conditions, and are designed for absorption through the oral mucosa. Chewing gum consists of two parts: a water-insoluble chewable gum and a water-soluble bulk portion. The gum base can be made out of natural or synthetic gums. Chicle, a natural gum base, is obtained from the sapodilla tree, but most modern gums are made from synthetic gum materials such as polyvinyl acetate. Advantages include limited first pass effect with a rapid onset of action. They are preferred by children and teens. They stimulate saliva flow, which decreases tooth decay. Some disadvantages include that gums can also adhere to fillers and dentures. They can cause facial muscle fatigue. Saliva washout can also occur. They are also a choking hazard, and how patients choose the gum can also affect how much of the drug is absorbed. Factors that can affect the release rate of a chewing gum are dependent on the ingredients in the gum and the patient's individual chewing patterns. A chewing time of 30 minutes is considered appropriate for gums, and a chewing rate of 60 chews per minute is recommended to establish a standard for this dosage form. The water solubility of the gum's components affects how quickly the active pharmaceutical ingredient is released. Hydrophilic drugs will release much quicker, and the lipid-soluble drugs will remain in the gum longer, allowing a gradual release. I want to start off by saying that this image is generated from ChatGPT, so don't get too worked up on its anatomical accuracy. But I promise you that this is way better than anything I would have been able to draw by hand. The nasal cavity can be partitioned into 4 compartments. The blue arrow is the vestibule located inside the nostrils. The green arrow points to the olfactory mucosa. The orange arrow is the nasopharynx associated lymphatic tissue, and the purple area is where our respiratory mucosa is. The central portion of the nasal cavity is covered by the respiratory and olfactory mucosa and is the most vascularized part of the nasal cavity. This area is the most important for drug absorption after intranasal administration. The mucus that coats the nasal cavity is continually moved by the cilia towards the nasal pharynx. Once a drug reaches the mucus layer, it must either dissolve or cross it before it's broken down by enzymes in the mucus or before it's removed by the cilia. The mucus layer in our nose is thinner than the rest of the respiratory tract. Particles trapped in the mucus layer flow at a rate of around 5 millimeters per minute. Once the drug penetrates the mucus layer, the drug must then pass the epithelial membrane composed of pseudostratified columnar cells that are tightly bound to each other. The majority of drugs that are of low molecular weight and that are lipophilic pass through this membrane through passive diffusion. Once the drug passes through the epithelial membrane, it can then be absorbed through the capillary endothelium. Intranasally administered doses of medications should be limited to 100 to 150 microliters, as doses greater than this can potentially cause a partial loss of the drug through the nostrils or posteriorly through the nasopharynx, creating an oral drug. The droplet size of the medication should have a range of 10 to 120 micrometers in diameter. This is because smaller particles would cause the medication to be inhaled into our lungs, and larger droplets would lead to deposits of medication in the anterior portion of the nose. Nasal inhalers are small drug-soaked devices that are used for nasal inhalation. Inside the plastic container is a fibrous material that has been embedded with aromatic substances along with the active pharmaceutical ingredient. These cylindrical devices usually contain a cap that must be removed and is then inserted into our nostril. Once the patient inhales this causes air to pass through the inhaler, pulling the vapors out of the device into the nasal passage. Liquid preparations are the most common dosage forms for nasal administration. They are advantageous because of their humidifying effects, which helps relieve the crusting and drying of the mucous membranes that is often associated with nasal conditions. Squeeze bottles are usually plastic bottles with a simple jet outlet. When squeezed, the air inside the bottle is pushed out of a small nozzle. This atomizes the liquid on its way out of the bottle. These are easy to use but are not practical options when precise dosing is recommended. Because of this reason, this dosage form is better suited for the application of normal saline, where precise dosing is not an important factor. Another disadvantage of this formulation is that the bottle's contents often become contaminated with the patient's microorganisms and nasal mucus after use. Metered dose pump sprays provide measured doses of solutions, emulsions, and suspensions. These dispensers can be designed for unit dosing or can deliver several hundred metered sprays. These devices instill a fine mist into the nostril by a manual pump mechanism. Most nasal formulations are considered a subset of inhaled products, meaning they should be sterilized. There are exceptions, such as nasal inhalers, because the fibrous material does not make contact with the nasal mucosa. The patient is only inhaling the vapors. Because of the risk for microbial growth, most liquid nasal formulations typically have preservatives, unless they are single-dose units or have a built-in barrier to prevent contamination, such as a one-way valve. The use of a barrier method is preferred as preservatives may have a negative effect, such as irritation to the nasal mucosa. In the US, there are only a handful of nasal powder products. These are Baqsimi, Onzetra Exhale, and Adzumi. Onzetra Exhale requires breath activation by blowing through the device to close the soft palate, limiting oral absorption and depositing the medication in the posterior nasal cavity. Advantages of nasal powders are that they do not require preservatives, they have minimal excipients, and have enhanced chemical stability, extending their shelf life. Solid-state powders are less conducive to, to microbial growth when compared to aqueous formulations. And that was your dose for medication education. I do hope you enjoyed today's video. If you did, please give me a like and subscribe. I would greatly appreciate it. Any comments are welcome. The reference slides are to follow. Thank you and have a good day.